Welcome to the Helping Patients with Substance Use Disorders and Pain conference call. My name is Larissa, and I'll be your operator for today's call. At this time, all participants are in a listen-only mode. Later, we'll conduct a question-and-answer session. Please note that this conference is being recorded. And I'll turn the call over to Nida with CCC webinar series. Please go ahead.
Thank you, everyone, for joining us on our last webinar for 2012. We have Jennifer Sharpe and Roger D. Weiss, who will speak on helping patients with substance use disorders and pain. I would like to encourage everyone to hold your questions for the end of the webinar. You have an opportunity to type it in the dashboard in the Q&A feature, and we'll get to you then, or you can wait till the end, and we'll open up the lines for questions. But at this time, I'd like to turn it over to Roger Weiss, who can give us a little something about himself and his affiliation with the CTN, and then he'll hand it over to Jennifer. So thank you, Roger. Please go ahead.
Thanks very much. I'm Roger Weiss. I'm a psychiatrist at McLean Hospital in Belmont, Mass., and professor of psychiatry at Harvard Medical School, and I've been with the CTN since 2002 as the PI of what used to be called the Northern New England Node, and now the New England Consortium Node. And I'm going to turn it over to Dr. Jennifer Sharpe-Potter, who's going to be beginning the presentation. Then I will be speaking a little bit later. So, Dr. Potter?
Thanks, Roger. So my name is Jennifer Potter. I am in San Antonio, Texas at the University of Texas Health Science Center. Previously, I used to work up in Boston in the New England Node. I am a psychologist by training, and I have been with the Texas Node for the past couple of years. I think that's probably about it about me. And what we're going to be talking today about, obviously, is chronic pain and substance use disorders. And I think just a couple things to orient us. The way that we have set this presentation is to look largely at a population of individuals where the primary issue we are looking at is substance use disorders, and they may have chronic pain. Another way to look at this might be to look at individuals in a pain treatment setting or in a primary care practice who have chronic pain, and there are concerns about substance abuse, misuse, or a substance use disorder. So in some ways, we're setting this in a substance abuse environment, and we can certainly talk to it from the other perspective during the question and answer, but I just want to kind of orient everyone to that because I think that's one of the issues that can get confusing in this. So what we'll start with is talking just really a little bit about what exactly do we mean when we call pain, when we say the word pain and chronic pain, and then we'll go into some more details with that. And obviously, I think it's difficult for us to have a conversation about pain without also talking and substance use disorders without at least setting it in the context of the problem with prescription drugs, narcotics, painkillers. So we'll talk a little bit about that. We'll present some data from a recent CTN trial with a focus on pain and how that was looked at in that, as well as the overall results, because that was an opiate abuse study. And then we'll get into some more details about some nuts and bolts kind of practical strategies about things that it might be useful as substance abuse treatment researchers and providers that we can use in our day-to-day activities related to pain and how we address it in the context of our care. So let's start. That was my outline, which I didn't show you. I think, oops. Sorry, I'm having a little trouble here. Okay, so this is not so much an outline as in some ways sort of our learning objectives, and I just talked a little bit about this. So we'll go through all of this. But the first thing that we wanted to start with was what is pain? And this is a definition from the International Association for the Study of Pain. And I'm just going to read this to you. Physical pain is an unpleasant sensory and emotional experience associated with actual or potential tissue damage or described in terms of such pain, or such damage. And the first thing I just want to flag about this is that when you read this definition, complex though it is, this really points to the issue of the subjective nature of pain. So there is a physical component, but it's also how that individual experiences that. And I think that's really foundational to how we understand pain in the patients that we work with in substance use disorders. So the way, when Roger and I were first learning about this, that a colleague of ours, Nat Katz, talked about it, who is a pain specialist, he said if they say they're in pain, they're in pain. And that's really the way, in many ways, we're judging a lot of these chronic physical pain complaints in general everyday practice with pain. So I think that's something to think about, and what that means when we're dealing with people who say they're in pain. The second definition I want to mention is chronic pain, and this definition can vary a little bit, but the definition that we'll be using when we're talking about it right now, and it's generally accepted, is continuous or recurrent pain that persists for 3 months or more. Now, there are definitions of chronic pain that have been 2 months and 6 months, but there's something about this 3 months that if someone has had the same pain complaint either intermittently or constantly for 3 months or more, they start to fit this category of chronic pain. And another thing about when we think about pain is that we're going to say the word pain as if it's one thing. When I'm saying pain, I'm mentioning a lot of different types of pain. So there can be low back pain, there can be headache pain, there can be acute pain post-injury, there can be pain where we really don't know what the cause is. For example, in low back pain, it's very often the case that we can't really identify the reason that there is this chronic low back pain that the person is experiencing. We can't actually isolate the source or the cause of it. And so it's something else to think about when people say they're in pain. Where is it? What type is it? How intense is it? And we'll talk a little bit more about assessment in a little bit. I'm going to pause right now and mention I talk very quickly. If I am speaking too quickly, Tracy is primed to look at the question and answer and hear that I'm talking too quickly and to slow down. So I'm very happy to get that feedback, but I'm attempting to slow down now. So let's look at this next slide. So when we think about physical pain, now I'm not talking necessarily about chronic pain, but just how often do people endorse physical pain in our treatment-seeking substance abuse populations? And so this is data that we looked at several years ago now from DATOS, which was the Drug Abuse Treatment Outcome Survey data. It was a very large data set of treatment programs throughout the United States. And as part of that assessment, they asked what type of pain, and how severe people's pain was at that moment, how severe their physical pain was. And when we look at this, we can look at residential treatment programs, inpatient programs, methadone programs, and that's been cut off, but that's psychosocial treatment programs. And you can see a substantial number of patients have pain at any given point in time. The most common treatment setting to see physical pain is in a methadone population, at least according to this research. And that's actually not surprising because when we looked at this a little bit further, the people that were most likely in our substance abuse populations to report pain were individuals who were misusing the opioids. And now looking back at that, that makes a lot of sense given some of the epidemiologic trends we've seen about the rates of physical pain in substance abuse populations. So nowadays, when we're looking at a population of methadone patients or individuals who abuse primarily the opioids, heroin, or prescription drugs, you can pretty confidently expect to see about a third of those individuals who actually go beyond just saying they have physical pain, but actually have chronic pain as we would define it, that's 3 months or more. The severity of that pain might be different, but if you just want to take a ballpark, if you walk into a population that's dominated by opiates, individuals with an opioid use disorder, you're about a third of them you can expect to have chronic pain. So when we think about this from a treatment perspective, that's actually a pretty important comorbidity to think about, particularly if it affects our treatment outcomes for our substance use disorders. So why did this happen? It's real important to put this in some context because when we're thinking about this, we're actually realizing that even more so than heroin, there's a robust problem that we have now with the prescription opioids, which I'm sure is not coming to a shock to anyone who's on this call today. So let's just look at this. This is relatively new. Some of you may have seen something like this in the published reports, but I just think it behooves us to take a look at this for a couple of reasons. So if we look here, Tracy, can they see this arrow if I wiggle this around that I'm waving over 91?
I'm sorry, no, they are not able to see it. If you click at the bottom of your screen, there's an arrow.
I see it.
Yeah.
Okay. Is it now working?
Click pointer, the one that says pointer.
I I feel like a dum-dum, but I am pointing it, but it doesn't seem to be working. Okay, well, I'll just do it with my words. If you look at 91, obviously, the prescriptions in millions were dramatically lower than if you swing along there and look at 2009. So there's just a lot more prescription opioids in our environment because there's so many prescriptions being written. It obviously permits the possibility of abuse and diversion, and that was really what I wanted to point out with that. I also just want to point out that if you look at that red bar, that's hydrocodone. So the prescriptions are much more common for hydrocodone than they are for oxycodone, and that's not necessarily always the case in our perceptions because of some of the issues that have come out with OxyContin and the publicity around it. There actually are more prescriptions written for hydrocodone. Okay. But I think this is actually a little bit more interesting, and I apologize that I didn't put the site on this. This is, if anyone's interested in pulling this, this is off of the Centers for Disease Control, which actually has in their Center for Injury Prevention now a pretty robust program looking at injuries related to opioids, overdose, and emergency room visits, et cetera. But what I like about this is if you look at these three lines, you're looking at deaths as a result that have been attributed to opioid prescription-related. You're looking at treatment admissions for opioid-related substance use disorders, and you're looking at the sales of the opioid prescriptions. And I think that, to me, this really tells on one slide a story that's pretty compelling because as we've seen an uptick in the number of prescriptions, we've also seen an uptick in deaths and individuals seeking treatment. And that's really, I think, probably why many of us are here today and why there's so much of an interest because presumably the prescription was prescribed for a pain complaint, but somehow what's coming along with that is a lot greater increase in problems related to opioid use disorders and negative health consequences associated with them. So just to summarize, opioid analgesics now, if you did not know this already, are the most misused drug class in the United States among all drugs of abuse, second only to marijuana. In 2011, the second highest rate of past year dependence or abuse of illicit drugs was seen in opiate analgesic users, with 1.8 million meeting diagnostic criteria for an opioid use disorder. And in that same year, there were 4.5 million non-medical users of opioid analgesics. With this last bullet, I just want to point out that when we talk about non-medical use, we get into another challenge with the opioid, defining opioid use or misuse, is that there's a lot of different ways to say this. So when I say, or when the statistic says that there were 4.5 million non-medical users, it doesn't necessarily mean all of those individuals were abusing. That can include a mom giving that to a college-age student of theirs because that child hurt themselves playing a sport. It can be a friend sharing it with a friend, presumably for a medical reason because that individual is in pain. It doesn't take away the safety concerns and the issue that it wasn't prescribed for that individual. But there's a continuum of reasons why people are non-medical users or classified as such, and I think that's just something important to keep in context with how we look at this. Sorry, I keep forgetting where to click. One other thing, then this just came out relatively recently that I got this information, is I also wanted to take a look at sources of pain reliever, and this again gets back to this issue of non-medical use. So this is a figure that looks at non-medical use among past year users who were 12 years old or older in 2010, 2011, in this year. So this is from National Survey on Drug Use and Health, and this again is available at the SAMHSA site. So the larger circle reflects the source that the individuals who are non-medical user got it from, and you can see that the most common source was free from a friend or a relative. Over half of individuals who report non-medical use get that free, get that Medicaid pill from a friend or a relative. What you can also see from this is, if you look at some of these smaller ones, look over to the left in that purple piece of pie, and you can see that the drug dealer stranger is actually relatively small, at least by this report, 3.9%. The green bar and the red bar are from one doctor, is the red, 18%, and then obviously this bought or took from a friend or relative is 16.6%. The lower circle is a pullout of the people who received their pill that they reported was non-medical use, free from a friend or a relative. Where did they get it? And it's overwhelmingly the case that the source where the individual who gave it to them free for a friend, for a relative, was one doctor. And that really raises the concern about the prescribing issue that we're hearing so much about, because a lot of this still, the supply of abusable prescription drugs appears to be coming in this way that's very alarming, and that's why there's issues now like the drug take-backs that are happening in a lot of the United States in collaboration with the FDA, where there are community sites where you can go in and turn your pills because they're trying to get opioids out of the drug supply. If you don't need it, you shouldn't have it lying around. And so we want to have a place to give it back to, because pharmacies can't just take these medications back, unfortunately. So there's really no clear way to dispose of them, which is why many people wind up with a whole bunch of them in their medicine cabinet. Okay, so just before we move on to Roger, just a couple other things to think about. It's important as we think about this, because this is, from my perspective, such a hot-button issue. I mean, the Wall Street Journal just had, I don't know if anyone saw it, but actually I have it on my desk. The Wall Street Journal on Saturday had a story where Wes Portnoy, who's a pain specialist who's largely known for his work in cancer and was pivotal in terms of really speaking to the issue of appropriate pain relief for individuals who are suffering, just talked about his perspective on opioids, because a lot of his work, rightly or wrongly, was used to make an argument that prescribing opioids for pain was something that was appropriate and we should use as part of a way to provide appropriate access to pain relief for people. So I think the reason I'm mentioning that is it's not the case that prescription drugs or prescription painkillers are inherently bad. And I think when we see so many patients coming into our clinics struggling with this, it's important to remember not everyone who uses a pill for pain relief or an opioid, that's not inherently bad. They can be safe and they can be very, very necessary for a lot of people, providing tremendous pain relief. The threat comes from when the abuse and diversion happens, and that's why I was showing some of those other slides to you. Another concern is that, and you may have seen this in for the folks who work clinically, may have seen this in some of their patients, is just because prescription drugs are legal and prescribed by an MD, they're not necessarily safer than illicit substances. And the example I always think of is a young woman I worked with who was shocked to think that the pills that she was abusing, the opioids that she was misusing and abusing, were in the same class as heroin, because she felt that heroin was such a dirty, nasty thing to be doing, and surely she was doing something much less damaging or hazardous than that. So we just wanted to mention that as well. So with that, I'm going to hand it over to Dr. Weiss, and he'll go through a study that we did and why it was done.
So thanks a lot, Jennifer. I'm going to be speaking about the prescription opioid addiction treatment study that was done as part of the National Institute on Drug Abuse Clinical Trials Network. And for people that are interested in the design of the study and the results of the study, which I'll go through now, these references on this slide, you can read all about it. So the prescription opioid addiction treatment study was the largest study ever conducted for prescription opioid dependence, with 653 participants enrolled. And we compared treatments for prescription opioid dependence using buprenorphine, naloxone, and counseling. It was conducted as part of the NIDA Clinical Trials Network, which is a partnership between researchers and community drug abuse treatment programs to carry out multi-site studies in community programs. And we initially examined detoxification from opioids as an initial treatment strategy. And for those who were unsuccessful, we looked at how well people did on buprenorphine's stabilization. And in both of these cases, patients were randomized to receive either standard medical management alone or standard medical management plus drug counseling. So I'll talk a little bit about the study design. The initial phase of the study, or phase 1 of the study, was a 1-month taper off of opioids using buprenorphine, plus a 2-month follow-up. People who did well, meaning that they were either abstinent or nearly abstinent with essentially just being detoxified from opioids, were successfully finished with the study. People who relapsed went into a second phase of the study in which they were re-randomized to either standard medical management or standard medical management plus opiate drug counseling in the second phase. And the second phase consisted of 3 months of buprenorphine stabilization, then a 1-month taper, and then 2 months of follow-up. So this fairly complicated diagram shows what happened. And so what I'll do, let's see, can people see, let me see, this is the pointer, but the pointer doesn't move. So
that's not working.
Okay, so it doesn't work. So basically, what you see on the left side of the slide is that people were randomized to standard medical management or what we called enhanced medical management, which was standard medical management plus counseling. They got a 1-month taper using buprenorphine naloxone and 2 months of follow-up, and you can see that on the top and the bottom of the slide. They were either at the top of the slide, they're successful, and at the bottom side, if they are successful, they're done with the study. And successful basically means that they were abstinent from opioids or nearly abstinent. 1 or 2 slips was considered okay. If they relapse to opioids, what's called failure here, then they go into the second phase of the study, where they are randomized again to standard medical management or the standard medical management plus counseling. And in the second phase of the study, they get 3 months of buprenorphine. At the end of the 3 months, they are either successful, meaning that they are, again, abstinent or nearly abstinent in the 3rd month of treatment. Then they get a 1-month taper and 2 months of follow-up. So this slide shows where the study was done. It was done at 10 sites throughout the country, and they included both urban and rural and suburban sites, and different types of sites as well. So the key eligibility criteria for this study, patients had to have DSM-4 criteria for opioid dependence. So what that meant is that they couldn't just be physically dependent on opioids and having a tough time tapering off. They had to have actually been abusing the medication and admit to abusing it. They had to have used at least 20 days of opioids in the previous 30. Patients with additional substance use disorders were considered eligible if they didn't require immediate medical treatment for that substance use disorder, and they had to be non-psychotic and psychiatrically stable, but we did accept people with other psychiatric disorders. Now, what happened to that slide? There's nothing there.
Which slide are you looking at, Roger? 17?
Yeah.
It's up now?
It's up?
I see nothing.
It says factors in defining a study population, heroin use and chronic pain?
Not on mine. I see nothing. I'm sorry. Let me see what happens when I go to 18. Nothing again. I'm stuck on 17, actually.
I think that might be a
local issue.
Yeah.
Why don't I go back and let's try it again?
Yeah, I don't know what to say.
That's okay.
Okay, key eligibility. Okay, so I'm on 17. It's still blank. I just get these random kind of weird, unintelligible drawings that show up on my slide.
Well, is it okay if I can read you what the slide says and then you can speak to that?
Well, here's 18. 18 came up. Heroin-related exclusion criteria.
All righty.
Sorry.
So 17, Roger, was just the deck that said that the heroin and chronic pain
was an issue.
Yeah.
Okay. Now somehow it just went back to 17. Now it's 18 again. So with heroin, if people used heroin for more than 4 days in the previous 30, they were excluded. If they had ever met criteria for opioid dependence as a result of heroin use alone, they were excluded. And if they had ever injected heroin, they were excluded. And the idea here really is that a lot of prescription opioid-dependent patients have used heroin at some point in their lifetime, so we wanted a population that was generally representative. But on the other hand, we wanted to make sure that this was a different population and was largely prescription opioid-dependent. Chronic pain obviously was a big issue to try to figure out how we were going to design the study around that issue. Many, but not all, subjects with prescription opioid dependence have been prescribed opioids for pain. The fact that they are quote, prescription users and even may have prescriptions doesn't mean that they actually have pain. And then there are plenty of people who have pain who use opioids but get them illicitly. So we tried to figure out how to deal with all of that. And what we decided to do is that subjects were prescribed who had been prescribed opioids for pain by a physician were included in the study only if the prescribing physician approved their entering the trial. People with cancer pain were excluded. People who had had a major pain event or traumatic pain event within the previous 6 months were excluded. And patients had to be interested in stopping their opioids, not just reducing their dose in order to enter the trial. So these were the study questions. Does adding individual drug counseling to buprenorphine naloxone pharmacotherapy plus standard medical management improve outcome? And to some extent, this was seen as a proxy for a question of if you were a physician that was prescribing opioids for a patient and the patient was clearly taking too much and you both agreed you should get off of this stuff, and the patient said to you, and you said to the patient, I think you should go to a drug abuse treatment program, and the patient said, no, I don't want to go to a drug abuse treatment program where they have all that counseling and stuff. I just want you to take me off of the medication and I'll just see you. This was designed to help the physician answer that by either saying, no, you'll do much better with a lot more counseling, or, okay, I can see you and you'll do reasonably well. A second question was how successful is an initial detox strategy? If a patient is just tapered off of opioids, how many people will do well with just that question? Among people that you detox that don't do well, does adding counseling to buprenorphine and standard medical management in a longer stabilization period make sense? And how many people do well on buprenorphine stabilization? And finally, do the answers to these questions vary according to whether the patient has current chronic pain or whether they have ever used heroin? So the study treatments, first, was buprenorphine. Now, buprenorphine is a partial opioid agonist, so it only partially occupies the opioid receptor. So it has effects that are typical of opioid agonists at lower doses, but it has a ceiling effect at higher doses of buprenorphine. And it binds to opioid receptors in a very tight way and is longer acting than most opioids. We really don't, in the context of this particular presentation, we don't have a lot of time to go over buprenorphine itself, but wanted to just give a brief introduction to it. It's a safe and effective therapy for both opioid maintenance and detoxification in adults. It's slow to dissociate from receptors, as I mentioned before, so the effects can last even if somebody misses a dose and it's FDA approved for opioid-dependent individuals who are 16 and older. So that was one of the treatments. Another treatment is standard medical management, or SMM. It was a manualized treatment that was conducted by Buprenorphine certified physicians. The initial visit was 45 minutes to an hour, and follow-up visits were 15 to 20 minutes. And in the standard medical management visits, the physician would assess for substance use, craving, and medication response and side effects, and would recommend abstinence from all drugs of abuse and self-help meetings. The individual opioid drug counseling provided education about addiction and recovery, recommended abstinence and self-help, and it provided skills-based interactive exercises and take-home assignments, and addressed relapse prevention issues in significantly more detail than standard medical management did, including high-risk situations, managing emotions, and dealing with interpersonal relationships. So, to talk something about the study population, again, we had 653 patients that entered the trial. 23% had ever used heroin. 42% had current chronic pain, which was defined by self-report as pain other than withdrawal, and we were careful to be clear that they weren't just describing withdrawal pain, beyond usual aches and pains for at least the past 3 months. You can look at the baseline sociodemographic characteristics: 40% female, 91% Caucasian, which is pretty typical of the prescription opioid population as a whole, 5% Hispanic, average age 33, and there were no differences between the standard medical management group and the people who got standard medical management plus opioid drug counseling. So this, for people who like pictures rather than text, this gives you an idea of the characteristics in graphical form of the patient population. This status, and it shows that it was a largely full-time employed population, which is very different from studies of heroin addicts, in which a lot lower percentage ordinarily is employed, and employment has a very good prognostic characteristic in drug-dependent patients.
Roger, your voice just dropped in and out a couple times, just to be aware of that.
Okay, I'll try this. If you look at their opioid, their substance use in the previous 30 days before entering the trial, one of the things that you see is that this is a group of patients who really landed on opioids and did not use a lot of other drugs. So they were, almost everybody was using opioids virtually every day, but very little other substance use. Again, considered a good prognostic characteristic. Mean years of opioid use, only 4.5. Again, a relatively short period of opioid use compared to heroin-dependent populations, again seen as a potentially good prognostic characteristic. 70% were cigarette smokers. The most frequently used opioids in the past 30 days, sustained-release oxycodone, things like OxyContin, was the most commonly chosen opioid among this population, with immediate release oxycodone at 19%. So what's important here is that hydrocodone is a much more widely prescribed medication than oxycodone, but oxycodone was clearly much more likely to be abused in this population than hydrocodone. An interesting facet about this population is that only 30% of them have ever been in treatment for opioid dependence before. So, again, very different from a heroin population, and
seen as potentially a good prognostic factor. In terms of the maximum buprenorphine dose prescribed during the treatment, the target dose was 16 milligrams. The allowable dose was between 8 and 32. We did find that 16 and 12 milligrams were the two most commonly prescribed doses, with 16 being the most commonly prescribed dose in both phase 1 and phase 2. So the results of the study, the first question was, does adding drug counseling to buprenorphine plus standard medical management improve outcome? So this is the results from phase 1, and the answer to that first question is no, but the more dramatic component to our result is not the lack of a difference between drug counseling and no drug counseling, but the extraordinarily low success rate for people in phase 1, i.e. just a 4-week taper. You can see what the criteria are for successful outcome in phase 1. Basically, that they're abstinent from opioids or nearly abstinent, but an extraordinarily low rate of success with this taper. Phase 2, things are very different. Not different in terms of the effective counseling, because again, there's no statistically significant difference between counseling and no counseling. However, what you see is a huge difference in the overall percentage of patients who are abstinent or nearly abstinent while taking buprenorphine. And if you look at the criteria for success in phase 2, patients had to have been abstinent for at least 3 of the final 4 weeks, including the final week, according to both self-report and urine test. So the 49% success rate at week 12, that's the end of the buprenorphine treatment, drops approximately in half when you go by the end of the 4-week taper between weeks 13 and 16. So you've gone now from 49% down to 26%. And then in the 8 weeks of follow-up after that, you see about 2/3 of those patients that were still successful at week 16 have now relapsed by week 24, and we're back into a percentage of success that is pretty similar to what we saw in phase 1. So the second study question, which we've sort of already answered, is how does the length of buprenorphine treatment affect outcomes in patients with prescription opioid dependence? Shows dramatically that the answer is dramatically. Phase 1, the success rate with a 4-week taper and an 8-week follow-up is 7% off just with a taper. Put them on buprenorphine and they're stabilized for 12 weeks. 7 times as many people are doing well. And then you drop down from 49% down to 9% with the taper. And these are obviously statistically significant. What predicted outcome? Well, first we looked at some of the things that we thought might predict outcomes, such as sociodemographic characteristics, gender, race, ethnicity, or smoking status, and none of those predicted outcome. Something that did predict outcome was heroin use. Among people who had used heroin, even though they'd only used it a little bit, because if they used it a lot, they were ineligible for this study. If you had ever used heroin, you did worse than if you had never used heroin. So if you look at the end of the stabilization period, week 12, if you had ever used heroin, the likelihood of success was only 37%, whereas if you had never used heroin, the likelihood of success was 54%. There was no statistically significant difference at week 24, in part because so few people were successful. Now we can talk about chronic pain participant outcomes, and I'm going to turn it back over to Dr. Potter.
Okay, thanks, Roger. So just to tee up some of the things we'll be talking about in the last portion of the presentation, we wanted to present a little bit more about what happened to the folks who did have chronic pain. And again, it was roughly 274 of the people that we randomized that had chronic pain according to our definition, or 42% of the population. So one of the things that we learned from this study was that these folks in many ways looked quite similar, and you can see looking at the gender, the age, their race, and years of education, they weren't actually that different. And that's not necessarily what all of us, I think, a priori had expected, but in this large sample we did see that. And also in terms of their substance use histories, they weren't particularly different. So if you look at these sort of common indicators of characteristics of history, their years of using opioids was not particularly different. It certainly wasn't significantly different. Their addiction severity index, composite scores for alcohol and drugs were rather similar, albeit for their drug composites relatively high. Their lifetime heroin use was a little bit more of a spread, but again, such that the individuals with chronic pain had not used heroin as frequently, but again, not a dramatic difference. So they were relatively similar. So now what I wanted to do is talk a little bit more about the folks that are in treatment or sought treatment in our study that had chronic pain, and some more things about their chronic pain. So the two big things to look at are the severity of the pain, and even in some ways more importantly, the extent to which that pain interferes with their lives. And so to do this, we used a common assessment called the brief pain inventory. It involves some questions about severity at different points in time, the week, that moment right then, the worst pain you've had, your average pain, and your least pain. And on average, their pain severity was a 4.4 on a 0 to 10 scale. And in terms of their pain interference, it was similar, 4.2. And pain interference means did it get in the way of normal activities? How much did it interfere with other things in your life, with sleep? And it's just a basic indicator of functionality. So if I was to go into, say, a chronic pain clinic, I would expect to see severity and interference scores that were probably quite a bit higher than that, probably in the range of 7. So these folks have moderate pain on the low moderate side of pain severity and interference as a result of their chronic pain. There was a bit of a split, with some of them having 42% having that pain constantly, and then 54% of them having intermittent pain where it came and it went. And the vast majority of these folks had this pain problem for more than a year, 81%, and over half of them had actually had the pain for 4 or more years. And when we talk about the types of pain that we see people coming in with or complaining of, what we see a lot of is the low back pain. And if you're in a clinic that sees individuals with chronic pain, this probably jibes with what you see, is that a lot of it is musculoskeletal pain, a lot of it is back pain related, and often it's whole body. So there's multiple areas that they might endorse as being painful for them. So this, I think, has been borne out by the sort of epidemiologic studies as well as what we saw in our clinical trial, that the pain that typically people are coming in with, although certainly there are others, is this back pain, this musculoskeletal pain, the knee pain and the extremities, and those types of pain issues. And it's not flipping. Hang on one sec. Okay. So we also asked individuals why they used. And the first question we asked was their major reason for first using. And this was the individuals who met our criteria at baseline for chronic pain. And 83% of those folks attributed the major reason for their first use as being that pain, and only 13% said that it was to get high or some of the other more illicit reasons for using that we might typically think of for folks coming into our treatment programs. We then asked those same participants, the individuals who said that the reason they first used was for pain, why they were continuing to use. And what we noticed was an interesting shift, because now only 22% of those folks said that the primary reason was because of pain. 56% of them now were reporting that the reason they were continuing to use was to avoid withdrawal. So you can see the shift in the primary reasons why people are using. And again, these are all our treatment-seeking patients from the prescription opioid trial. And this slide does not work on this format. It works in slideshow, but not here. So what I would show you in this, if it was a little bit clearer, I apologize for that, is that when we ask people for their important reasons for using in the most recently, like why their most important reasons for using in the past 6 months, overwhelmingly individuals said the most important reason across 16 different reasons for use was to avoid withdrawal. But and that was regardless of their pain status. But what we actually saw for the individuals with chronic pain versus the individuals who did not have chronic pain, for the second most important reason why they were continuing to use, was a split there. And the individuals with chronic pain continued to say that pain was a major reason for use, whereas the individuals without chronic pain did not endorse that reason at all as an important reason for using. So they were clearly not using for pain. So you can see that even though withdrawal, the point of that messy slide, the point is to point out that while withdrawal is a major reason for use, the second most important reason for individuals with chronic pain was pain. And while that may seem obvious, I think it's an important point clinically when you start to think about this as a clinician, about how you're going to address, in addition to any other treatment that they're receiving, the functional relationship between pain and their substance use. Okay, so when we actually looked, the next question would be, in the POATS trial, was there something different about how these individuals responded to our buprenorphine treatment because of their pain status, or it was not because of, excuse me, in a causal sense, but was there something different about how these chronic pain participants responded to our treatment? So I just wanted to point out to you that when we looked at this, we saw that individuals with chronic pain were no more likely to drop out of our buprenorphine taper in phase 1. Just as a reminder, that was that 4-week taper, the 2 weeks of stabilization followed by a 2-week taper. They were no more likely to drop out than the individuals without chronic pain, nor were they any less likely to enter phase 2. So they entered phase 2 at the same rate as the individuals without chronic pain. And we didn't see any evidence that they were more likely to have an SAE. The reason why we looked at these three things was because at the time when we began this trial, one of the things we were interested in was, does having chronic pain status have some type of differential effect on your ability to go through a taper or a maintenance? And that really wasn't known at the time, and that's why we're pulling this out. So from the perspective of an opioid replacement therapy, these individuals didn't really respond any differently overall than people who didn't have chronic pain in terms of basic safety indicators and treatment retention. And interestingly, from my perspective, they also didn't have any differential treatment response. So there was a school of thought that when we put people with chronic pain into this treatment, some people thought they might do poorly and not respond that well compared to the non-chronic pain patients. And some people thought they might actually do quite well. Well, it turns out they do about the same. And you can see that from this. So when we're looking at that stabilization period, their response rate significantly improved according to our primary outcome from that main trial, was about the same. They did slightly better, but it was not significantly better than the individuals without chronic pain. So that's another piece of information to take away, is that at least according to our study, individuals with chronic pain did just as well in terms of an overall treatment response as individuals without chronic pain. We also were interested in what happened to their pain during the trial. And what we see from this is that when we looked at, I mentioned the brief pain inventory, we looked at their intensity scale. We looked at how severe their pain was. And from the perspective of the pain world, when we can see a treatment response of 30% or more reduction in pain within an individual from baseline to when we follow up with them, that's considered a moderate improvement in their pain status. And you can see, if you look at the shaded middle column, that 51% of the chronic pain participants experienced 30% or greater reduction in their pain severity over the course of the trial. Now, I can't tell you that was because of anything in particular. Certainly they were taking buprenorphine as part of this, although they were not being treated for their pain using buprenorphine. But they were stabilized, they were put into substance abuse treatment, and over the course of that process, they had 51% of them had a moderate improvement, and you can see a third of them roughly had a substantial improvement where their pain severity was cut in half. And I mentioned initially that functional interference is also important, and one of the ways we can look at an indication of improvement in functional interference is to look at a 2-point change over time within an individual in terms of interference improvement. And 43% of our sample did have, in fact, that level of improvement in terms of the interference of their pain in their lives. Okay, so just to sum up POATS, in terms of chronic pain participants, the chronic pain participants did just as well as those without chronic pain. We didn't observe any particular safety concerns, and many had significant pain improvement. A couple of caveats to that would be that these were individuals who were treatment-seeking patients for a substance use problem. These were not individuals with chronic pain showing up at their primary care office or at a pain clinic or other treatment venues specifically requesting treatment for pain. What we saw in terms of pain was something that was sort of secondary. In fact, these individuals didn't know we were even going to look at that. They were coming for treatment for prescription drug abuse. It was a very mixed group, as you saw, of a variety of types of chronic pain, and we didn't have any control over that. It was just who showed up at the door. And while we did see a pain improvement, there was no control group. This was not a controlled trial looking at some type of a specific treatment for pain. It just was something that we looked at in secondary analyses. So with that, we wanted to close. And I think we're going to have plenty of time for questions. We wanted to close with some basic thoughts about assessment, diagnostic issues, and managing chronic pain participants. So we'll go through that now. To put this in context, I just want to mention a couple reports that have come out, the most recent one being in earlier this year, I believe. And if the slides were distributed, these are actually hyperlinks that you can click to these. These are Institute of Medicine reports on pain care principles. And the gist of it is, I won't go through all of these, is that there's a tremendous amount of suffering as a result of physical pain that is not being adequately met by our current healthcare system. And that there is a problem with over-reliance on medication approaches, even in the face of evidence-based treatments that are non-medicine-based, that are as effective or arguably more effective. So we do have a slate of evidence-based practices that are underutilized, and that was really the gist of what they wanted to put forward, and that we need to really do a better job of addressing pain in this country, particularly in light of the problems that we're having with the opioid prescriptions and emerging beyond just the abuse of opioids, emerging concerns about long-term chronic exposure to opioids as a healthcare issue. Because I did not mention this, but many, many trials have been done on opioids and their pain reduction. Very, very few of those trials have looked, if any, at long-term outcomes with the chronic opioids, with opioids used chronically for a chronic pain condition. A couple things that I think are important as we're thinking about understanding this. If you're going to start thinking about chronic pain in your patients, it's important to start thinking about how you might navigate with pain specialists and folks who are clinicians who are working with patients from the perspective of their pain. And one of the things is that in our world, in the substance abuse world, we use the word dependence quite a bit. And we need to be sure that we're clear who we're talking to and what we mean by dependence, because physical dependence is a different phenomena from a substance use disorder. And it's not sufficient for an individual who is physically dependent on an opioid to meet criteria for an opioid use disorder. So we have people who've been taking opioids for quite a long time, very appropriately, following their doctor's advice, that are physically dependent on that pain medication, but they are not addicted. And when you talk to pain specialists, it's important to be clear about our terminology. And in fact, DSM-5 is actually going to have language in there that will, as it's currently written, that will not allow a diagnosis of an opioid use disorder to be made that includes tolerance or withdrawal as 2 of the 7 criteria. Did I get that right, Roger?
You did.
Okay, good. I went and looked, but I wanted to make sure. So the key part of that is that physical dependence will not be used to define an opioid use disorder in an individual who is receiving a prescription for that medication. So I think it's important to be paying attention to this, and it's in partial response to some of the issues we've had with the opioids. Okay. I borrowed these from Deb Haller, this particular slide, so I've acknowledged her with the holler on the side. But when we're thinking about assessing pain and talking about pain, and I'll make an argument that I think it's very useful for us to ask our participants, our patients, I'm sorry, I do so much research, I keep calling everyone a participant, to talk with them about pain is to remember, as I said before, pain is a subjective experience, and that individuals will have varying responses to pain according to a lot of factors. And a true pain assessment requires a comprehensive clinical evaluation beyond more than just how bad you're pain right now. But that's not necessarily something that's practical to think about in our substance use treatment programs, which is why it's useful to think about under what circumstances it's useful to engage a pain clinician as part of their treatment or to have some type of dialogue with them or a primary care provider. The other thing I just want to point out to us, because we might not realize this in the substance abuse world, is that physicians, there are health disparities. There's evidence of differential treatment and assessment and attitudes by ethnicity and race. And I think it's important to realize that as we're thinking about how people are being evaluated, because it is possible that some of the individuals that we work with in addiction actually have terrible pain that may not be being adequately treated. And when somebody says that, it's not necessarily the case that they're just a drug seeker. They may have very real and valid pain complaints that aren't getting addressed. So that's just an example of one thing related to that. In terms of pain assessment, if we're thinking about doing it in a more quick and dirty way, there are a lot of different ways to do it. One is a pain scale, and this is actually a DoD VA pain scale that's a hybrid of just using faces. So when we ask kids, oh, there, my mouse is working now. When we ask kids about pain, we often show them little faces, and these do a pretty good job of showing how extreme their pain is. And then we also are able to use a numeric rating scale, rating it from 0 to 10. Well, this one integrates a variety of things, mild, moderate, severe, the faces, the numbers, and then down below descriptions so that they're very clear anchor points. So that's one way to do it. My particular favorite is the next one, and very similar to depression, where it's been reduced down to 2 questions that in primary care can be used to assess depression. These are 3 questions. It's called the PEG. I won't go through it all, but this will be available to rate pain. And you can see, going back to what I mentioned before, there's 1 question related to severity, and then there are 2 questions related to pain interference. And these 3 questions do a pretty darn good job of giving us a good sense of pain severity overall. So that's the type of question that would be useful to think about, I personally would recommend in the context of our treatment programs. In terms of what we know about treating patients with substance use disorders, unfortunately, although I think this is going to change very quickly over the next few years, because there are studies in progress, we don't have a lot of evidence about treating chronic pain in the context of a substance use disorder. So there have been 2 studies, and I'll just mention the last bullet here, 2 studies that were not randomized controlled trials looking at using cognitive behavioral therapy to address pain and integrating relapse prevention into that seemed to show a pretty good effect. And that actually makes a lot of sense. The evidence base for using cognitive behavioral therapy for chronic pain is actually very, very good. And it's considered by a lot of the evidence-based practice guideline organizations as being an effective treatment with high support. And for example, the American Psychological Association Division 12 has a number of things that meet that category for effective treatment. So it doesn't surprise us that if we combine that with relapse prevention, that might be a good strategy. And in fact, when we did when we did CTN 30, what we decided to do to address chronic pain, because we knew we were going to have people with chronic pain, even though this was not a chronic pain study, we wanted to at least have a way of addressing it. So the way that we did that was we had an orientation for all of the counselors where a pain specialist, Bob Jamison from the Brigham and Women's Hospital in Boston, came in and talked to our providers that would be working in the study about pain. And then we also had a module that the counselors could use in the individual drug counseling to address pain. But the overall approach that we took was to build awareness in the participant and have a conversation with them about how pain was related to their drug use and might impact their outcome. and the session goals more specifically are outlined below, but it really was talking about using and thinking about pain as it was functionally related to slips and triggers and other things that we would talk about in the context of relapse prevention. And that's available in the manual if anyone's interested, but this was the basic idea, and I think it builds on all the principles we already do. It's just being mindful to pull in the issue of pain if you know there's a pain complaint. So this is my little model of this, and this is borrowed from the dual diagnosis literature, which talks about the degree or the extent to which we need to integrate services with the chronic pain side, with the opioid use disorder side. And the idea behind this is that if they're doing pretty well, obviously the level of intensity of care, the level of intensity of care is not necessarily the same as when people are at more acute level of presentation on either of the disorders, although no care seems a bit strong on that. So the idea would be is that collaborative care starts to emerge as the severity of the disorder increases. So for an individual, for example, with a severe opioid use disorder who also has chronic pain, well, their treatment home might be a substance use clinic. It's important to consider including a pain specialist as part of care. So one of the takeaway messages that I would think from this that we have found to be useful, and in fact at McLean Hospital, where I used to be and where Dr. Weiss is, we actually had a physiatrist who would come to we have a physiatrist who comes and rounds at the detoxification unit, the inpatient unit at McLean Hospital for individuals with chronic pain. And so that relationship, and that's been going on for a number of years, that relationship is so that that individual can do consult with participants and patients and try and understand what's going on and provide recommendations as part of good comprehensive care. Okay, so some just very general recommendations about addressing pain in the context of our substance use patients. It's important not to ignore the pain. One of the things that I've learned from doing this for a while and also from some qualitative research and other literature is that very often pain is invisible. You know, when you initially have an injury, people pay attention to how you're feeling and they hear your complaints, but as time goes on, individuals with pain, particularly chronic pain, can start to feel a little bit invalidated, and that sense of acknowledging that individual as experiencing pain can oftentimes be very helpful to them and very appreciated. And it's important not just because for that individual. I would actually suggest that it's actually important to monitor that pain and chart it in some way, in a systematic way, so that you have a sense of what's going on and are there any patterns in relation to their pain that might be important in terms of their substance use treatment. It's important to ask about their pain treatment history and know what they've tried and what they haven't tried. Very often, individuals with chronic pain, if it's gone on for a while, have tried a lot of things. But it is really important to know what other medications they're taking. You would be surprised, or perhaps not surprised, at how many individuals in methadone treatment, for example, actually have a prescription for an opioid at the same time. I personally was naive to that and was surprised when I first started asking those questions, how many prescriptions for opioids were being prescribed while someone was coming to the methadone clinic. And it's important for everybody to know that information. As we've already said, I think one of the things I would argue for is that there is this interrelationship between pain and substance use, even non-opioid substance use. There's literature that people actually drink in response to pain, particularly when they don't have access to an opioid. They will use the alcohol in response to the pain. So it's not just an opioid. We need to pay attention to it all. And think about if there are ways to incorporate pain into your treatment planning, not necessarily because you're there as their pain provider, but because there might be this relationship between their pain and their substance use, so that that's the best way to optimize their recovery for the substance use. And obviously, if you have questions about that, we can take them at the end. I do want to shift briefly to the other side of the occasion and think about, well, what if somebody with a substance use history does indeed seem to be in a situation where they might benefit from an opioid? How do you do that? and how do you do that safely? The reality is we don't actually know how one does that safely, but there have been some guidelines that have been recommended by the American Pain Society and other pain organizations in collaboration with some of the addiction societies to try and come up with some recommendations. The evidence base is not strong, but these things on the face of it seem like reasonable approaches to managing an individual who has a substance use history that is going to be receiving an opioid for chronic pain. So this is an opportunity to include the pain, to include the opioids in their treatment. Frequent visits, small quantities for a lot of obvious reasons, I hope. Long-acting doses as opposed to short-acting. And the key to this is no rescue doses, and that relates to the last bullet point as well, with no PRN dosing. So they're on a schedule for their dosing rather than given an opportunity to take the medication PRN. It's beneficial to encourage them to use only one pharmacy, watch for early scripts or lost scripts, consider using urine toxicology, so understanding that this individual in agreement with their provider will be subject to urine drug screens, preferably randomly, so that they can have that as part of their treatment, which will provide some additional structure to how they use that medication. And to encourage that in some cases there might be important to coordinate that prescription and that chronic opioid therapy with their addiction specialist and other wraparound services related to maintaining their recovery for this substance use. I won't go through this one extensively, but this is some recommendations for generating an opioid agreement. So one way to structure the treatment might be to actually have an opioid agreement in place with the provider and the patient such that everyone's on the same page about what's going to be happening to their treatment while they're getting that opioid. And the reason why this is important is because another thing that I think it's useful for us to understand is I think there's some misconceptions about the actual efficacy of opioid therapy for chronic pain. As I mentioned already, there are very few randomized controlled trials of long-term chronic opioid therapy and its effectiveness. And the studies are flawed, and that's been borne out by a couple studies. The ones here, as an example, there's a very nice Cochrane report, as well as a review that Bridget Martell did. I'm actually going to skip this one. One of the things to be aware of is when you're working with pain providers is some of the language that they use, and one of these ideas is pseudo-addiction. Pseudo-addiction being this concept that an individual who is undertreated for pain will behave in ways that look like addiction but really aren't. Because it's actually a reflection of them not being adequately treated. So that's a term. It's being used less and less, I think, but it's something to be aware of. But there is the issue, as I mentioned before, of is someone being undertreated? Do they need more adequate pain care? And are we actually seeing some of the problem opioid use behaviors, the things that we might be concerned about from an addiction perspective, because they don't have adequate pain care? So it's a complicated issue. A resource that I wanted to mention to you is Said and Savage. Did a wonderful, she actually was at a CTN blending talking about this, and she's been at other meetings. She has a wonderful write-up and comments that really talk through what we might benefit from knowing about pain in persons with substance use disorders. And so it's a really, really terrific primer. It's available on the web. It was published by NIDA, and you can read that and really get a really nice primer on chronic pain that would be useful and practical for you in your work. And then these are just a couple other resources. This was one published by the CPDD, and then it's a little bit older, but Jane Ballantyne and John Mao did a very nice write-up about concerns about opioid therapy for chronic pain in the New England Journal in 2003, and subsequent studies have actually borne out a lot of the concerns that they articulated at that time. And these are, I think we're through. So, Tracy, is this the time for questions?
Yep, this is the time for questions. Thank you both. We don't have any questions in Q&A, but I think that some of our participants have some questions they'd like to chime in, so I'm going to hand it over to Larissa. And if you could give instructions on how to ask questions.
Thank you. We'll now begin the question and answer session. If you have a question, please press star then 1 on your touch-tone phone. If you wish to be removed from the queue, please press pound sign or hash key. If you're using a speakerphone, you may need to pick up the handset first before pressing the numbers. Once again, if you have a question, please press star then 1 on your touch-tone phone. Standing by for questions. And I am showing no audio questions at this time.
Okay. Well, I don't want anyone to feel shy, so if you feel there's even, a short question you'd like to ask, please do so. We'll leave it open at another minute.
We have a question from Christy Taylor.
Yes, the question I have is, with the changes in the DSM-5 ruling out tolerance and withdrawal symptoms, I'm fearful that this is going to make it more difficult for us to get our substance abuse patients certified through insurance companies. Do you have a response to that?
Yeah. Well, DSM-5 is making a number of changes, but you only need so one of the things that's happening in DSM-5 is that the distinction between abuse and dependence is being eliminated. Those two terms will no longer be used. It will just be called a substance use disorder, opioid use disorder, alcohol use disorder, etc. The abuse and the dependence criteria are going to be lumped together, adding craving and taking out legal consequences. And you only need to meet, I believe at this point, 2 criteria to meet criteria. And then there will be a specifier, mild, moderate, etc., that I think will be probably based on number of criteria. I don't know all of those details. But if a patient is, for example, let's take opioids. If a patient is prescribed opioids, by definition, they're going to have physical dependence and probably tolerance. If they don't have 2 other of the criteria, 2 of the behavioral criteria, then they shouldn't be in addiction treatment. Just being physically dependent without any of those other criteria means they're just physically dependent. So I don't think it's going to be an issue that there are people with multiple problems that can't make those 2 criteria. Right now you have people that meet the criteria who don't have a problem, and I don't think the other thing is going to happen.
Christy, one thing that might help with this too is we actually were concerned about this issue because all of this was an issue when we started the trial, and we, although it's not published, we actually went and looked at individual criteria for DSM-4 and compared individuals with chronic pain and without chronic pain because we were curious to know if we had people who were just squeaking in and had 3 criteria. And we overwhelmingly found for individuals with chronic pain and without chronic pain that they had 6 criteria. So we actually were wondering the exact same thing, and it was not a problem. If we had taken out the 2 criteria, tolerance and withdrawal, I think the vast majority of individuals with chronic pain would still have met criteria to be in our study.
Right, and remember that in the future, there's not just going to be 7 minus the 2, but there's going to be 11 or 12 minus the 2. Because you have both the dependence and the abuse criteria together.
So it's interesting because we don't know. We're changing, and it's a difference, but at least I think what we've seen would suggest that we're not going to have the potential issue. What payers do is a completely different thing.
Yeah, that's a different consideration.
So there is a question on the Q&A from Tom Metcalf. Has cannabis use been studied as a pain management issue?
Well, there are cannabinoids including the synthetic cannabinoids that people have sort of turned into things like spice and K2 that were originally developed to be analgesics. So there are cannabinoid compounds that may be useful as analgesics, and that's actually a pretty hot topic of research. But that's not really what they're being used primarily for now. But it is an area of, I think, fairly intense research as people are looking for alternatives to opioids.
Great. Tom, does that answer your question? Okay, we'll have to assume that it does. And Linda Lai has another question. You alluded to other, Tom says yes, by the way. But moving on to, you alluded to other evidence-based pain treatments. Besides CBT, what other treatments are available?
Do you want me to take that one, Roger?
You can take it, and you say, and then there may be some other things that I'll think of as well.
Okay. So if we take it out of the realm of non-medication, there are a variety of psychosocial treatments under the umbrella of CBT. So there's mindfulness-based pain interventions that have worked and have been evidence-based. There's something called acceptance and commitment therapy, which, while it might fall under the umbrella of cognitive behavioral therapy, is a little bit different than what we might think of as a typical skills-based cognitive behavioral approach. And actually could post a table if you wanted. If you go to the Cochrane reviews, there are a variety of other approaches. There's some evidence looking at, and the thing with pain is one of the difficulties is that there's usually modest evidence because not everything works best for everyone. I can pull up a few others. I mean, quite honestly, mine are more the psychosocial approaches, so they're ones working with individuals in group or individual settings related to psychosocial skills training. But there's the studies of acupuncture, there's physical therapy, and a variety of other ways to look at pain. I'm probably sort of fudging that a little bit because I want to make sure I'm getting it right, so I can talk about that a little bit more. Roger, I don't know.
Yeah, and there are other non-opioid medications that are sometimes used in the context of chronic pain, including antidepressants, with tricyclic antidepressants probably being better than SSRIs, or the more noradrenergic antidepressants generally being better than serotonergic antidepressants. Anticonvulsants, such as gabapentin, have been found to be useful in some people with neuropathic pain, and then in addition to the things that Jennifer was just talking about.
The guidelines and the evidence for multidisciplinary pain management programs, so it's not one individual approach, it's actually multidisciplinary treatment, are often the ones that are most recommended. Unfortunately, they're the least used right now for a variety of reasons. An example might be something like functional restoration, and functional restoration is trying to, as the name sounds, bring them back to functioning, and that's done through a variety of approaches, but it's multidisciplinary treatment. So they might have a physician on board, they might have a physical therapist, there would be a psychologist, and there is goal setting around that, but the goal is to get them back to a functioning approach. So that would be another way to think of it. They're complicated to deliver in the context of a substance abuse program.
Great. And any other questions, please chime in.
We have a question from Cynthia Calera.
Oh, hi. I have a question. I don't know if you do the studies, but if you've noticed, with the rise in their prescription of the opioid analgesics, what I'm seeing in my practice, I do drug and alcohol counseling in California, is there's been an incredible increase in heroin use. Mm-hmm. Have you noticed that? Is anybody recognize this as a problem?
Yeah, I think that the rise and fall of different drugs of abuse are very much local and regional issues, and different parts of the country you see spikes of different drugs. In Boston, we had a big spike in heroin use that has been has shifted much more toward prescription opioids. And a lot of these folks use both. They go back and forth between the two, depending to a large extent on availability and price. Once somebody becomes opioid dependent, whether they start by using heroin or start by using a prescription opioid, then they're very likely to use the other one if it becomes easier to obtain.
Well, it seems that, one of the statistics you showed is that we don't even know, or there hasn't been any real studies done on the efficacy of the use of opioid analgesic with back pain, but nonetheless, these analgesics are being prescribed hand over fist and making addicts. Or, I'm sorry, people who are dependent on opioids.
Yeah. Well, as Jennifer really talked about early on today, not only the addiction, but prescribing practices have, there's
really risen, yeah.
Yeah, well, there's fashion with prescribing practices as well, and in the 80s and 90s, the fashion was to avoid opioids, and then there were people that said we're withholding opioids from people that need it, which was true, but it led to people probably giving opioids more to some people who didn't necessarily need it. I think there's probably going to be a shift back again toward more judicious prescribing of opioids. And there could be a reduction in this particular issue, and there'll be some other drug of abuse that pops up.
The other thing, just on that issue, I think in fairness to the providers, primary care providers and pain specialists, and in fact I think a lot of the prescriptions that we're talking about do come from primary care providers. In fairness to them, I think that it's a complicated system in which they have to deliver pain care. So they're told they need to relieve pain. They have very little time to visit with their patients, and they have a concern about patient satisfaction. And an example of that would be there was a very nice piece in JAMA, I think it was in April of this year, that talked about this, and I happened to have it because I was working on something else, and the title of it is Patient Satisfaction, Prescription Drug Abuse, and Potential Unintended Consequences.
Oh, yeah, I read that. That was terrific.
It's a wonderful piece because it really talks about how difficult it can be to be a physician with all of the pressures from all of the different stakeholders in providing health care. And so I think it's something to understand what it's like to be one of those docs when you have, and when your patient's coming in saying, this is what I want, and managing that. So I just wanted to mention that. The other thing, I was feeling badly about my rather poor answer about other strategies. I just wanted to mention a couple others. Self-management interventions. There's some really great self-management interventions for pain. There's evidence that if you can put somebody in weight management programs so that they can lose weight, that actually can be very beneficial. And there's actually some evidence that just exercising so that people with musculoskeletal pain actually start to exercise. And that's why McLean has a physiatrist, for example, can also be useful. So when I was talking about other evidence-based practices, that's what I was referring to.
Well, I certainly think that those would be helpful, and in California, I understand that the difficulty that the physicians are under, because we have something called the patient's Bill of Rights, which says right in it that a patient has the right to have their pain addressed.
Right.
So the physicians are in this pincer between patient satisfaction, but also trying to avoid creating people who will then have another issue, which would be the substance abuse issue.
Right.
And it is. I mean, just what I see, the tragedy I'm seeing with the heroin use and the prescription drug abuse dependence. It's just tragic.
Yeah, and I think it's unfortunate because we're seeing the tragic consequences of some of this, I think there's a danger of kind of an adversarial relationship with our colleagues, and I've seen it at some early pain meetings where people from cancer, for example, would stand up at these joint meetings and be just outraged at the addiction folks for saying, you're just saying this is killing people and you're not understanding the benefits of this. And so I think the more we can walk in each other's shoes, if you will, to understand it, because it's really complicated how we wound up where we are, I think.
Well, and I think you're right. I think it is just, and I'm going to take a look at this JAMA article because you address one problem and then you create, it's a hydra. More monsters come out.
Right.
Okay. Thank you.
Okay. Any more questions with the operator? Please.
I'm showing that. Sorry. We have a question from Stephen Roth.
Yeah, this is Dr. Rue. I'm a medical provider in methadone treatment programs, and I had a question for you. It was alluded before that, a large percentage of methadone patients also have prescription medications for opioids. Some of them actually have legitimate pain, I'm sure. But for me, anytime I've ever tried to communicate with either the chronic pain provider or the primary care specialist, they run for the hills like I have leprosy.
Oh, yeah.
So I'm calling to see whether or not you all have any recommendations on how I can approach them a little bit better and get some sort of ability to coordinate care with them. Because
do you find similar difficulties with other communicating with physicians about other issues, or it's about this particular one?
It's about this particular one.
Yeah.
It's like if I'm providing methadone, so they just want to say, well, thank you very much. Now I can let this patient go.
Oh, that's the thing. So I get it.
Yeah, like I said, some of these people actually have legitimate pain problems.
Yes.
And we already know that methadone by itself, a single dose, the way we generally give it in the programs, is not going to give them pain relief.
Sure.
More than maybe 8 hours of the morning.
Right.
One of the things we've been doing here is that when I first moved here, I went to the pain clinic, and they said they'd be happy to work with me, but they needed me to promise that any addiction program I worked with that they might want to interface with would not abandon them. And so I think that there's some concern that they're going to get stuck with these folks, and so when they find someone to take them, there is that. But what we've been trying to do is build that communication, which may be easier in certain places. San Antonio's medical community is relatively small, so that there's that specialist relationship with the pain practice, so that they know that we're not completely relying on them to take them, that we can have them as consult on pain, and that we're going to continue to manage that patient. So.
Yeah, it sounds like there's almost a game of hot potato of if you call this person, the question is which one is going to abandon the person.
Pretty much.
And if you don't want to do that or certainly have the other person do it, I'm just trying to brainstorm here, one thought would be to draft essentially a form letter that you send in these circumstances saying, you've got this patient that you're treating that's in this program, and you understand this person's prescribing an opioid. It would be great if you could work together on this issue, and you'll be calling soon. Maybe there's a greater likelihood that when you call, if you say, I don't intend to drop them, and I don't want to inherit their pain care, let's work together. Maybe there's a better chance.
No, I can redouble my efforts at that particular one, because I'm generally open to trying to let them all know, look, I can manage the substance dependence, I can monitor the drug screens for you, I can do all of that kind of stuff.
Right.
But I don't want the DEA looking at the 7 million milligrams of methadone that I prescribe every month.
But they have to take your call and talk to you in order to learn that. And
exactly.
So that's why I think the letter might help.
That might work. I think I might try that way.
Okay.
All right. I appreciate that.
Sure.
My fear is that so many of these folks have had so many different failed procedures and things, and that pain specialists don't actually like to be writing prescripts for opioids. I think it's typically they turf that back to the family docs. And so what happens is they don't really have anything to offer. So if they think of themselves as a consult and a specialist, that you are just engaging in a conversation, that might buckle. That letter idea, I think, is perhaps the way to do that.
That's a good one. I appreciate that one.
Wonderful. Thank you, Dr. Rue.
Thank you.
We have one last question from Tom Metcalf. He's wondering if there are other studies coming in the pike on the length of time in treatment and intensity, types of treatment, multidisciplines involved, and will any of this be conducted? And I'm sorry, this will have to be our last question.
I'm sure there are other studies going on. I don't really know. I know it's an area of a great interest in terms of either both treatment of prescription opioid dependence. I know that there's been there's a study at the University of Vermont on different detoxification schedules that I heard presented about a year ago. And so I imagine a paper about that will be coming out one of these days. We're doing a longer-term follow-up study on the population that we talked about and are looking at right now the data about how these folks are doing 1.5 years out. So it's certainly a hot topic in an area of intense interest, and I think there will be more to come.
So if there are any other questions, please feel free to send them to ctntraining@ms.com. I want to thank everyone for participating. Drs. Potter and Weiss, thank you so much. This was a great session. And basically, we will send in the survey, so please respond to the survey, and we'll see the rest of you in 2013. Thanks so much for your time.
Okay. Thanks. Bye-bye.
Thank you, ladies and gentlemen. This concludes today's conference. Thank you for participating. You may now disconnect.